Thanks, Dr. DeVascar, for the introduction and for inviting us here this morning to talk about pediatric cancer predisposition. I'll first give a brief background on pediatric cancer and pediatric cancer susceptibility. Then I'll discuss the application of clinical exome sequencing in identifying patients with cancer susceptibility. We'll introduce the Pediatric Cancer Predisposition Clinic, a UCLA genomics clinic, and then we'll end with 4 case-based vignettes of non-syndromic and syndromic patients with underlying cancer genetic predisposition and the role for cancer surveillance. We'll be touching on these bolded ACGME general competencies during the talk. So each year in the United States, about 16,000 children and adolescents under the age of 20 years are diagnosed with cancer. A newborn is born with a 0.3% probability of developing cancer by the age of 20, which translates to a 1 in 333 chance. So although cancer in children is extremely rare, about 2,300 children and adolescents die of cancer each year, making cancer the most common cause of disease-related mortality in the 1 to 19 years age group. There has been recent debate in the literature and the popular news about whether cancer is due to random bad luck. This is because there's extreme variation of cancer incidence across different tissue types. Some of these differences are attributable to environmental factors such as smoking, UV exposure, alcohol, and HPV infection. But environmental factors do not explain why, for example, cancers of the small intestine are 3 times less common than brain tumors, even though the small intestinal epithelial cells are exposed to much higher levels of environmental mutagens than are the cells within the brain, which is protected by the blood-brain barrier. It is noted that some cancers are attributable to inherited genetic variation, which is the topic of our grand rounds this morning, but historically this has been estimated to only be about 5% of cases. Vogelstein last year showed that stochastic effects of DNA replication can be numerically estimated and distinguished from external environmental factors. He demonstrated that the lifetime risk of cancers of many different tissue types was strongly correlated with the total number of divisions of normal self-renewing cells maintaining that tissue's homeostasis. And therefore, he concluded that the majority of cancers is due to, quote, bad luck, that is, random mutations that are occurring during DNA replication in normal non-cancerous stem cells. However, it's unclear how random cancer really is when it occurs in children, even though we as oncologists often try to reassure our families that it was indeed a random occurrence that their child is being diagnosed with cancer. But one would think that there would be higher rates of genetic cancer predisposition in the pediatric patient population who have, these patients have shorter environmental or carcinogenic exposures, more robust DNA repair mechanisms, and fewer numbers of divisions of these normal self-renewing cells. Heritable cancer syndromes are genetic disorders in which germline mutations in one or more genes predispose an individual to the development of cancer. Many of these are caused by mutations in tumor suppressor genes, DNA repair genes, or oncogenes. Of course, cancer inherently is caused by mutations in important genes that regulate cell growth and cell death, but these are usually somatic. So the onset of cancer in an individual without an inherited cancer predisposition is due to the acquisition of gene mutations in one or more somatic cells, such as would be shown here, that then ultimately alters the balance between cell proliferation, differentiation, and death, leading to uncontrolled growth and the development of a cancer. In a patient here that would have a heritable cancer syndrome, these are patients born with the germline mutation that would be passed from parent to offspring, except in cases where the mutation is de novo, meaning that it occurs in the affected child only, or in cases of mosaicism where the mutations may not necessarily be present in all of the cells. And Dr. Martinez will speak about some of these cases later. But because these patients are already born with a first mutation, they are at a higher risk of developing cancer and at an earlier age compared to that of the general population. So one example, One example that's pretty well known and widely studied is familial breast and ovarian cancer syndrome. These are patients with mutations in BRCA1 or BRCA2, and they have an increased risk of breast and ovarian cancer. This syndrome is widely studied, and there are established guidelines for the testing and management of these patients. In some families, preventative surgery may be recommended to greatly reduce the risk of breast and ovarian cancer. However, unlike this syndrome, our understanding of cancer predisposition syndromes in the pediatric population is lacking. Most cases are probably undiagnosed, and very few syndromes have established guidelines for management. So this is a table of just a select group of tumor types, their differential genetic diagnoses and causative genes. I put this here especially for the new trainees, because this may be something that could be tested, that you guys could be tested on. So for example, adrenocortical carcinoma, choroid plexus carcinoma, and sarcomas are often associated with Li-Fraumeni Syndrome, which is caused by mutations in TP53. Up to 80% of pediatric patients with adrenocortical carcinoma will end up having an underlying TP53 mutation. Atypical teratoid or malignant rhabdoid tumor is associated with rhabdoid tumor syndrome caused by mutations in SMARCB1 or INI1. It is thought that up to half of the patients that have rhabdoid tumor will have this syndrome. Desmoid tumors, and then less commonly we would see colon cancer in a pediatric patient, are associated with familial adenomatous polyposis caused by mutations in APC. Hepatoblastoma is also associated with FAP as well as Beckwith-Wiedemann syndrome, which Dr. Martinez will speak about later, caused by abnormalities in CDKN1C and chromosome 11p15. Optic pathway tumors are associated with neurofibromatosis type 1, caused by mutations in NF1. Up to about 10 to 40% of patients with optic pathway tumors are found to have this syndrome, and this is a major ophthalmologic complication for patients with NF1. Retinoblastoma can be seen in hereditary retinoblastoma caused by mutations in RB1. Up to 40% of patients with retinoblastoma will have an underlying mutation in RB1, which was actually the first tumor suppressor gene to be cloned. Wilms tumor, especially bilateral Wilms tumor, is associated with Wilms tumor syndrome and Beckwith-Wiedemann syndrome. Neuroblastoma, especially bilateral or multifocal, can be caused by underlying mutations in ALK, PHOX2B. GBMs can be associated with certain syndromes. Lynch syndrome, which is caused by heterozygous mutations in mismatch repair genes, MLH1, MSH2, MSH6, and PMS2. Of note, there's also a different syndrome caused by homozygous mutations in these same genes called constitutional mismatch repair deficiency, where you can also see brain tumors very early on. And GBMs can be associated with Li-Fraumeni syndrome. So what is the actual genetic contribution to cancer in pediatric patients? This is one of the earliest reports that came out from the United Kingdom in 1991, which reviewed records of 16,500 cases of childhood cancers that have been reported to their National Registry of Childhood Tumors. And they found that a genetic condition was listed for about 3% of these patients. And when they incorporated information about family history, they found that the total genetic fraction was estimated to be about 4.2% only. There was a study that looked at the incidence of malformation syndromes in children with cancer. Using clinical morphologic exam on just over 1,000 children with cancer, they found that 7.2% of patients were diagnosed with or suspected to have an underlying syndrome. The median age of these patients was lower than the median age of non-syndromic patients. Clearly, patients with cancer predisposition syndromes could be missed by this approach alone, as there are non-syndromic cancer predisposition syndromes, including Li-Fraumeni syndrome, which I'll be discussing later as well. This study from Cincinnati looked at hereditary cancer risk assessment in their cancer survivors clinic. Family histories were taken either in person by a genetic counselor or by completion of a screening form. They found that nearly 30% of patients were considered eligible for further genetics follow-up or referral. However, even this 30% may underestimate the true percentage of pediatric patients who should be have follow-up and workup by genetics because these are patients who survived 5 years from their cancer diagnosis, so it will have missed patients who didn't make it to their survivor clinic. So today we have the ability to utilize cutting-edge sequencing technology to comprehensively evaluate for various genetic disorders, including cancer susceptibility. Next-generation sequencing is a high-throughput DNA sequencing technology where millions or billions of DNA strands can be sequenced in parallel, yielding substantially more throughput compared to the classic Sanger chain termination method. UCLA was the first academic medical center to offer clinical exome sequencing, which covers more than 95% of the protein coding regions of the whole genome. And this essentially removes the guessing game in which clinicians have to pick and choose which heritable cancer syndrome we should test for, and especially can be helpful in cases where the phenotypes are complex and can even be cost-effective. So there have been a couple recent publications using next-generation sequencing to identify germline mutations in patients with pediatric cancer. This is a St. Jude study that was done with over 1,100 patients, less than 20 years of age. These patients had leukemia, CNS tumors, and non-CNS solid tumors. They performed exome and or whole genome sequencing and then RNA sequencing on a subset. And they identified a cancer predisposing gene in 8.5% of their cohort. They had mutations in 21 genes listed here, which you may not be able to see very well, but these mutations occurred in 94 patients, and you can see TP53 is by far the most common, with almost 50 patients having mutations identified in TP53. Baylor reported on a study using whole exome sequencing in tumor and blood germline samples from patients with solid tumors, newly diagnosed and relapsed. And out of their 150 patients, they found diagnostic germline findings related to cancer in 10% of their patient cohort. So given the growing evidence that genetic diagnosis of cancer predisposition is important and can also impact overall survival through cancer surveillance plans, as well as opening opportunities for potential chemo prevention, Dr. Martinez and I established a unique multidisciplinary clinic called the UCLA Pediatric Cancer Predisposition Clinic back in 2012. This is one of the UCLA genomics clinics staffed by Dr. Martinez, myself, neuro-oncologist Dr. Davidson, neurosurgeon, genetic counselors, Nagmi Durrani, as well as a couple social workers. We offer state-of-the-art clinical exome sequencing and interpretation for families with a possible genetic cancer predisposition syndrome. And we have a biobank and registry to prospectively collect data on these very high-risk families and to hopefully increase our understanding of new genes and their function. The clinic is on the first 2 Wednesdays of every month, and this is a chart of the number of patients that we've seen since we started almost 4 years ago. And as you can see, there's been a steady increase in the number of referrals, many of them from you here in the audience today, as well as the greater Los Angeles area, such that we've seen almost a tripling of the number of our patients since we started. So these are the general indications that we use to decide whether or not to order clinical exome sequencing for possible cancer susceptibility. This is only one of the many tests that we utilize in the clinic, such as microarray and methylation testing, which Dr. Martinez will expand on later. We order clinical exome sequencing when the targeted gene or panel testing has returned negative results. When the targeted gene or panel sequencing test is actually more expensive in some cases and could take longer than the turnaround time for clinical exome sequencing. When clinical testing for a suspected gene is actually not available, When there's a strong family history of cancer, but the pattern of cancers is not necessarily consistent with one specific disorder, and when there's a complex phenotype that could be associated with genetic heterogeneity. So this is the yield from clinical exome sequencing in our clinic. We have found that about 11% of our patients will have a likely pathogenic or pathogenic finding. 40% of patients will have no clinically significant findings, and then almost 49% will have variants of uncertain clinical significance. So our first case is a 14-year-old who presented with left knee pain. She ended up being diagnosed with osteosarcoma. She had no significant family history, but she participated in Dr. Fetterman's sarcoma banking and sequencing study here, and was found to have a de novo pathogenic mutation in TP53 consistent with Li-Fraumeni syndrome. And this is an example of a patient who had no particular indication, based on family history anyway, for an underlying genetic cancer predisposition, other than the fact that she's a child with a sarcoma that ended up being explained by a de novo or a new mutation in TP53. So Li-Fraumeni syndrome, this is an autosomal dominant cancer syndrome caused by mutations in the gene TP53. The incidence is unknown, but there's one US registry that has about 400 affected patients. The most common cancers are bone and soft tissue sarcomas, breast cancer, leukemia, and adrenocortical carcinoma. This syndrome used to formerly be called SBLA syndrome for these four most common types of cancers that are seen. The classic clinical criteria is a proband with a sarcoma diagnosed before the age of 45 years, and a first-degree relative with any cancer before the age of 45 years, and a first or second-degree relative with any cancer before the age of 45, or a sarcoma at any age. However, some use a more permissive Champret criteria, which expands the spectrum of malignancies in the proband to include sarcomas, brain tumors, breast cancer, and adrenocortical carcinoma. And it also allows a more permissive age, up to 56 years, for cancers diagnosed in first or second degree relatives. It's interesting to note that only about 70% of patients that meet the classic clinical criteria for LFS end up having an identified mutation in TP53. And when you look at the patients who meet the more permissive Champret criteria, only 20% of those patients have a mutation in TP53. So 50% of these patients will develop at least one malignancy by the time they're 30 years of age, and 90% of them will by the age of 60. And 1/3 of cancer survivors will develop multiple primary cancers over their lifetime. In one study that looked particularly at children, which emphasizes the need that children need to be tested for this, in 132 children, they found that 30% had osteosarcoma, 27% had adrenocortical carcinoma, 26% had CNS tumors, and 23% had soft tissue sarcomas. But there are actually a very wide variety of other malignancies that have been reported in smaller numbers, including melanoma, stomach cancer, lymphoma, Wilms tumor, colorectal cancer, and others. So this makes targeted cancer surveillance a challenge in this very high-risk population. The group at Toronto Sick Kids developed a clinical surveillance protocol using frequent biochemical and imaging studies for patients with LFS. During childhood, they recommend getting urine and blood tests every 3 months to look for liver tumors, leukemias, lymphomas, and adrenocortical carcinoma. They also recommend having the labs accompanied by every 3-month abdominal and pelvic ultrasounds. They in Toronto do a whole body rapid MRI, or in centers that don't have that available, they recommend doing annual chest, abdomen, pelvis MRIs, and then a dedicated annual brain MRI to look for brain tumors. During adulthood, it's recommended that they also incorporate breast MRI imaging as well as colonoscopies at around 25 years of age or 10 years before the earliest known age of onset of those particular cancers in their family. So this group conducted a prospective observational multi-site study with 33 patients, 18 of whom decided to undergo the cancer surveillance that I just outlined, and 16 decided not to undergo surveillance. And one patient is included in both groups for cancers that were diagnosed before and after the onset of the surveillance. So this was not a randomized study. The primary outcome measure was detection of new cancers, and the secondary outcome measure was overall survival. The surveillance protocol detected 10 asymptomatic tumors in 7 patients that were undergoing surveillance, and 12 tumors developed in 10 individuals in the non-surveillance group. And this is showing the survival curve of these patients. The red line here is the survival curve for patients who elected to undergo this rigorous cancer surveillance, and the blue line is patients who did not receive surveillance. So all 7 patients in the surveillance group that developed cancer throughout this study period survived, and only 2 out of the 10 who hadn't received surveillance were alive at the end of the study. This is not a perfect study. This was a small cohort with a fairly short follow-up, but it demonstrates the feasibility of a rigorous cancer surveillance plan and the importance of genetic diagnosis and its role in potentially impacting survival. So going back briefly to our case, this patient underwent this cancer surveillance plan, and she was found to have an asymptomatic brain tumor in the right parietal lobe, which was small and easily accessible and resected, although the family at this time has chosen not to resect it, but we were able to identify an asymptomatic tumor early for this patient who otherwise would not have been diagnosed with this. So Dr. Martinez will discuss 3 additional syndromic clinical cases and then conclude with a summary.
So typically some of the patients that we see in the clinic will present with stories like this. So this was an 8-month-old pair of twins who were born to a mother who had multiple pregnancies. In this case, it was a pregnancy that was the result of a monochorionic diamnotic twin pregnancy conceived through in vitro fertilization. The pregnancy was complicated by preeclampsia, and the babies were born premature at 32 weeks. And their weights were actually within normal limits, although for that stage of development were a little on the larger side, 6 pounds for one and 5 pounds for the other one. One twin was found to have microglossia, so a large tongue at birth, and persistent hemangiomas that developed over subsequent examinations. At that point, they were referred for a genetics evaluation, and the geneticist at that time had ordered genetic testing for Li-Fraumeni Syndrome and had found that they were positive, at least the one twin was positive for hypomethylation at Imprinting Center 2. They underwent a surveillance protocol that included an abdominal ultrasound, which showed a mildly enlarged liver and normal kidneys, and alpha-fetoprotein testing showed an elevated AFP at 32, with an echo that showed a septal defect in the heart. Turns out that the twin sister was phenotypically unaffected and therefore not tested by the geneticist, and the family was reassured that in the absence of symptoms, there was nothing to worry about. So this brings up the topic of discordant identical twins. So why is it that even though these twins are genetically identical, they look very different? So one twin has a very large tongue and is much larger than the one that is the sibling who looks otherwise unaffected. And the reason that they're different is because of epigenetics. And we know that in the pathophysiology of disease, we can look at genetic predisposition factors, but also the role of the environment in influencing the expression of genes. So epigenetic means that it's not in the genes, that these are changes in gene expression that are the result of factors external to the DNA, i.e. environmental causes or changes that affect the expression levels of a gene transcript. And these can be inherited or passed down with every cell division. So why are we interested in epigenetics? Because epigenetic conditions are different from gene-based ones, because epigenetic marks are sensitive to the environment. So we know that they're reversible, they can be changed, and therefore it's a dynamic process by which genes can be regulated, and therefore tissues can adapt to the environmental changing conditions. Epigenetic conditions have been seen in discordant monozygotic twins, so we know that that is a true phenomenon based on the fact that they share the genome, but they have different phenotypic representations. And because they're reversible, they are more attractive as potential therapeutic targets. So more and more we're seeing that the approach to cancer, both in the somatic and the predisposition field, is to try to figure out ways to change gene expression by not necessarily fixing the genetic defect, but by altering the expression of the transcript in other ways that are not genetic. So what are the mechanisms that mediate this epigenetic regulation of gene expression? So you have things like non-coding RNAs, adding methyl groups to the DNA sequence, positioning of chromatin modeling factors that then in the end essentially either activate or silence gene expression. So why is it indeed that these two twins, even though they share the same genetic material, look so different? And it's because, as I mentioned, they can have differences in the methylation of their DNA in one twin versus the other. And the reason that happens is that when you develop a twin, right, so you have the original zygote with its DNA and the modifications here in the genome in terms of methylation are represented in red. So once the twin happens, when the zygote divides into two cells early on, you'll have one twin that will maintain the normal pattern of methylation in its DNA, but the affected twin will actually alter its epigenetic signature and therefore create a process in which there is the possibility of overexpression of genes as it happens in Beckwith-Wiedemann. And the reason why that happens is still a mystery, but it could be sort of environmental factors, hormonal changes, or just stochastic, happening randomly by chance. So what ends up happening is that even though you have two identical twins, one will actually have productive transcription of a gene, but the other one will have an alteration in its epigenetic landscape that will turn off or on genes that normally should not be active or expressed. So in the case of Beckwith-Wiedemann, the reason that there's an epigenetic change is because there's a region in chromosome 11 in the P arm in band 1,5 where there's imprinting going on. And imprinting is a process that's required where the parent of origin of chromosome 11 has different methylation patterns because genes have to be expressed from the father's copy of the chromosome or the mother's copy of the chromosome to maintain normal levels of expression. So you will see that when the sperm is made, it has specific blue marks that are telling you that the methylation pattern are different from those in the egg. And when the two come together, then you have the actual right balance of gene expression. And that's established in the germline very early on when the egg and the sperm are made and passed on to the child. So why is imprinting or this methylation epigenetic process important? Because you have to regulate how well your body grows. And these are genes in this region that are very important for maintaining proper body size and growth early on in development. So we know that IGF-2, which is a very potent growth factor, is expressed there, and its regulation is maintained properly by allowing paternal allele to be expressed, but the mother's to be turned off. And we know that for experiments in mice, where if you tinker with the imprinting and you make it more paternal, you tend to have mice that are much bigger. If you make it look more maternal, then the fetuses are much smaller. So we know that the final size of the child at birth, and that continues postnatally, is determined significantly by genes within this region, and the right balance has to be maintained. So how does that happen? Well, it turns out that in the maternal copy of the chromosome 11, you have genes that are being expressed, and many of these genes are actually negative regulators of growth. So they are repressing the fetus from growing too fast. Again, because the mother is carrying a pregnancy in her body, she doesn't want a very large fetus. And then the paternal copy is actually silencing those genes, but it's allowing expression of those genes that promote growth, because you want a fit fetus when it's born to survive in its environment. So you have to have maintained the proper balance of negative regulators of growth with those that promote growth so that you have the right size of a child. What ends up happening is that this proper balance of positive and negative regulators gets altered, where you have alterations in the imprinting, where you now have twice the amount, for example, of IGF-2 expression, and that causes excessive growth. And that loss of imprinting causes the child to grow too fast, and that's how you get Beckwith-Wiedemann syndrome. So that's what we notice in one of the two twins. What is Beckwith-Wiedemann syndrome? So it's a prenatal and postnatal overgrowth syndrome. So these children tend to be big before, but sometimes after birth as well. They present with very large tongues. They don't necessarily always have to, but that is one of the typical signs. They can have omphalocele or umbilical hernias at birth. They can develop specific ear creases that you can see on exam and large organs internally. They can also have hemihypertrophy, so asymmetry of different parts of the body. It can be right through the middle or specific arms or legs. And it tends to be sporadic. They're very rare familial cases, and 80% of the time it will be due to one of these imprinting or methylation epigenetic alterations, with some subsets being mutations in the genes within or missing copies of the genes within the 11p15 region. So just to update you, it turned out that when we saw the twins in the clinic, you would have assumed, as the other geneticists did, that the second twin, because they were unaffected, was therefore not carrying the epigenetic change that the sibling had. But it turns out that when we tested the unaffected sibling, she also carried the IC2 hypomethylation. So she was at risk of developing the same tumors that her affected phenotypically twin had. So this just goes to show you what Dr. Chang already discussed, that even though you don't have any external manifestations, many of these children benefit from testing here because of an affected family member in order to get surveillance early on. So I spoke about Beckwith-Wiedemann and how you can have hemihypertrophy or asymmetry. We can see that hemihyperplasia or hemihypertrophy also in an isolated manner without any other symptoms associated with Beckwith-Wiedemann syndrome. And we know that that asymmetry is due to an increase in cell number and cell size on one side of the body or one portion of a body than the rest. Most of those cases are sporadic. It's relatively common. It's 1 in 86,000 children. And it's associated with increased birth weight many times. It's more common in females than males. And it tends to mimic mosaic overgrowth syndromes like Beckwith-Wiedemann, where one part of the body grows faster than the other. Sometimes when you look at the bone age, it could be advanced, and that's one early assessment that you can determine in these children. And some of their internal organs, like in Beckwith-Wiedemann, can be hypertrophy. So they can be enlarged or asymmetric, where one kidney might be larger than the other, or the same for the adrenal glands. So when we look at children with a hemihyperplasia, because of this phenotypic overlap with Beckwith-Wiedemann, we want to determine if they have simple or isolated hemihyperplasia, or is it associated with a complex syndrome? Are there other phenotypic findings that make it syndromic? And sometimes the asymmetry is limited to a specific embryological side of the body or a body system, whether it's brain, muscle, skeletal, or bone. Many cases have identified the same etiology, so the same epigenetic changes that cause Beckwith-Wiedemann end up happening also in isolated hemihyperplasia. But you have to look in the right place. If you look at the arm, for example, or the leg that is longer, and you actually did a skin biopsy, and you tested for methylation in that tissue, you would see those changes there, whereas if you tested blood, you would miss them. So that demonstrated to us that the fact that they share the same genetic cause demonstrates why they can present in an isolated form. And the reason they present with an isolated hemihyperplasia is that they don't have Beckwith-Wiedemann syndrome. They have a methylation change in 11p15, and it's because the change is mosaic. The epigenetic mutation is only present in the parts of the body that are bigger, but not everywhere, therefore giving you the isolated manifestation. So what are the things that we look for that we see in the patients that have overgrowth syndromes when they present with hemihyperplasia? So you're looking for macrodactyly large toes, extra toes or fused toes, bony problems, hip dysplasia. You want to look for visceral changes or large organs internally, changes in the kidneys, congenital heart disease like the child with Beckwith-Wiedemann did, genital abnormalities, which can include also changes in asymmetry of the organs of the genitalia. Changes in the CNS, macrocephaly is a big early sign, so a head that is growing faster than you should, even though there's no signs of hydrocephalus or increased intracranial pressure. Hemimegalencephaly, sometimes one side of the brain will be larger than the other on brain imaging, and that's an early sign of one of these syndromes. Or hemiatrophy, where one side is smaller than it should be for age. And then, of course, the presence of seizures. We tend to look at the skin very carefully because a lot of these patients will have cutaneous findings, so referring to a dermatologist is a good idea because nevi, hyperpigmentation, cutis marmorata, which is modeling of the skin, telangiectasias, thickened skin, increased number of sweat glands. All these things are actually signs of these overgrowth conditions. And of course, early eruption of teeth, large teeth, and changes in tongue size are also examples. So these are just things to pay attention to when you're doing a physical exam so that they can suggest to you more of a syndromic presentation. And when we look at syndromic presentations, the hemihyperplasia diagnosis turns more complicated, right? So instead of being mosaic, maybe it's a more broad presentation of Beckwith-Wiedemann syndrome. It could be due to a chromosomal abnormality that is mosaic as well, or it could be specific genetic syndromes that we know can predispose to the asymmetry plus the other physical associated findings. And each one of them has a distinct genetic etiology, which can be diagnosed and therefore a different prognosis over time. So what are the types of malignancies that are associated with hemihyperplasia or hemihypertrophy? The most common ones are Wilms tumor in 60% of the time, adrenocortical carcinoma, and hepatoblastoma. And there's also a number of others that we tend to screen for and that are much rarer. And if you notice, if you look at the malignancies that are associated with Beckwith-Wiedemann, they're very similar. So in Beckwith-Wiedemann, the most common ones are Wilms tumor, hepatoblastoma, adrenocortical carcinoma, and it's because, again, the genetic basis of that leg length difference, when it's isolated, it's usually similar to that of Beckwith-Wiedemann. And what ends happening is that you can't sample every tissue. So if you could sample the kidney, if you can sample the brain, you could then know which tissues are actually carrying this epigenetic change. And because you can't predict, there are recommendations by the American College of Medical Genetics that every child that has hemihyperplasia should get this screen, regardless, because you can't anticipate which organs are going to carry these changes, and therefore they should all be screened for these kinds of tumors. So when you look at the tumor frequency, depending on which syndromic presentation, you may have more commonly kidney versus liver tumors versus, for example, Soto syndrome, which rarely has adrenal tumors, but will have renal and liver tumors as well. And what we do is we screen with abdominal ultrasounds every 3 months, and that goes for whether you have Beckwith-Wiedemann or hemihyperplasia. It's exactly the same protocol. And then alpha-fetoprotein levels to detect liver tumors early, every 6 weeks to 3 months. And that depends on anxiety levels with parents, but also with the genetic etiology, because some genetic etiologies will have a higher chance of tumors than others, and we feel more comfortable spacing it out depending on which one it is. And we tend to do it until the age 7 to 9 because the risk essentially disappears after that. So this is another typical story that we see that is not subtle, but when you see it, it should raise a red flag. It was a 23-year-old female who at the age of 18 months was diagnosed with a big head. And this is the reason why I present this case, because the early sign for this individual was that the head was growing fast. So children that have heads that are growing fast should be a red flag for you pediatricians, particularly to look for developmental delay, asymmetries, and pay careful attention to their physical exam. By 7 years old, she had developed precocious puberty and significant menorrhagia. And because of that, she underwent ultrasound scanning, and that's how they found incidentally that she had a stage 1A or ovary dysgerminoma. So she already had a tumor at the age of 8 that was resected. Between the age of 9 and 12, she went on to develop these benign subcutaneous lipomas or fatty tumors and hamartomas. By the age of 12, she had an MRI of the back of the spine because of pain, and it revealed that she had hemivertebrae, so multiple malformed vertebrae from T10 to L3, which eventually caused her to develop scoliosis. By the age of 16, she had a thyroid tumor that was benign. By the age of 17, she developed severe vaginal pain and was found to have benign tumors in her breast as part of a general workup for hormonal causes. She was then found to have a cervical polyp that was removed, and a colonoscopy, because she had symptoms of severe constipation, identified 18 polyps, one of which was an adenoma, again at the age of 18. She then saw a dermatologist for a full skin exam, and she was found to have multiple growth of her skin. And then a follow-up thyroid scan then determined that her lesion had increased in size, and she developed additional ones which required thyroidectomy. By the age of 19, her breast tumors or her lesions that had been identified earlier had accumulated and grew so many that they couldn't actually differentiate them on echoes and surveillance, so they had to do a double mastectomy. By the age of 21, she continued to have this horrible menorrhagia, and she underwent a hysterectomy. So after this whole dilemma, she actually had trio exome sequencing, and she was found to have a heterozygous, likely pathogenic new mutation, so she didn't inherit it from her family. There was no family history of any of this, and she had a variant in a gene called PTEN. So you can see sort of these horrendous histories that we get, and it's only when you have genetic testing that you reveal the etiology for it and why surveillance is really important. So this patient has Cowden syndrome, which is a high-risk cancer predisposition disorder that leads to benign and malignant tumors of the thyroid, breast, and endometrium. It presents early on with macrocephaly, skin tumors like trichomoniasis. Lifetime risk of developing breast cancer is 85%, which is why she had the bilateral mastectomy. And she had, with an average diagnosis between 38 and 46. She has a lifetime risk for thyroid cancer of about 35%, endometrial cancer 28%. And PTEN is not the only gene associated with it. There are other genes like PIK3CA, AKT1, and SEC23B that are also cause Cowden syndrome. Turns out that mutations in PTEN cause other conditions as well, and I present them because these are the kinds of kids that you will see that you will never suspect have a cancer predisposition. So for example, a child that has macrocephaly, developmental delay, and just fatty tumors on the skin, you may not think has a predisposition, but he may have a mutation in PTEN and therefore be at risk for these particular malignancies. And then even children that just have a big head and autism have mutations in PTEN as well. So when you're screening for these children, these are the things that you want to check for. And what's interesting is that when you look at that subset of children that have autism and large heads, it's usually extreme macrocephaly the way they present with. So it's not a subtle macrocephaly around the 1.5 to standard deviations. It's way above the 98th percentile. So if you see children that are continuously have to have a very large head, even though they have no hydrocephalus, you've ruled out all other etiologies, you need to think about this and refer early so that we can actually do appropriate screening. And some of these children, so only 20% will have PTEN mutations, and we're finding more and more new cases in which these autism microcephaly cases have mutations in other genes that also cause predisposition to other tumors. So many of these patients still have genes that are yet to be found. So how are they managed? So obviously they get physical exams every 12 months in our clinic. They get thyroid ultrasounds before the age of 18 because again, those are the first cancers they're going to present with. Physical exams because they may develop hamartomas of the skin. They can get colonoscopies, and again, unless they're symptomatic, because it's the patient that we presented had severe constipation, and that's the only way that those polyps would have been found that early. But the recommendations are to start when they're much older. We usually do renal imaging as well, and then you can do self-breast exams when they're over the age of 18. But again, you can see that their lesions start really young. So PTEN and Beckwith-Wiedemann are part of a group of conditions that are called overgrowth syndromes, which individually are very rare, but as a group are very common. It's about 1 in 10,000 children will have one. And they present with advanced height and head circumference early on, so they tend to grow very fast, particularly before the age of 7. And they can develop additional comorbid conditions that we discussed earlier. So they're associated with an increased risk of cancer, particularly these solid tumors, Wilms, adrenal, and hepatoblastoma. And many of them will have either changes in genes that activate too much, because you have, for example, too much IGF-2, which binds to receptors like the insulin receptor, then activates the PI3K-AKT signaling pathway, which eventually leads to activation of TOR. And TOR is a powerful promoter of cell growth, so cell proliferation and survival. And the reason I mentioned this pathway is that these patients may benefit, particularly when they're diagnosed with a malignancy, from drugs that we know target AKT, PI3K, and TOR. And that might be good adjuncts for their therapeutic treatments. We also want to know what gene change they have because many of these genes will have different prognostic outcomes over time, and they may not respond to specific treatments. In fact, some of them may be toxic to them. So the frequency of tumors in overgrowth syndromes is also different. So depending on which of those conditions you may have 100% only kidney tumors versus ones that might have a more broad distribution between kidney and liver versus those that include the adrenal glands. So identifying the genetic etiology is important to target our surveillance. So this is a case of an individual in which the condition benefited from understanding the diagnosis because the treatments are very important in what to avoid. This was a 2-year-old that presented with headaches and increased clumsiness. A brain MRI showed that she had an enhancing mass in the midline of the cerebellum that caused obliteration of the fourth ventricle and hydrocephalus, most likely the cause of her headaches. Eventually, it ended up being a desmoplastic medulloblastoma, which is a rare type of cerebellar tumor. Turns out that she had developed this macrocephaly way before she had developed the tumor. She had right ear microtia. She was born with an ear that was smaller on one side, and she had curving of the fifth finger bilaterally. Subtle symptoms that you can kind of detect early on. The family history was limited because the mother was adopted, but we suspected that she might have fragile eggs because she had some history of delays. The father was not in the picture, so we didn't have the history. But she had a sibling who was an identical twin, who also had similar features. So it turns out that 2 to 5% of children with medulloblastomas will have an inherited predisposition, a germline mutation. And the most common one is mutations in genes that cause Gorin syndrome or Nevoid basal cell carcinoma syndrome. And the patient ended up having a novel de novo frameshift insertion to a pathogenic variant, a variant that will make the gene not work in SUFU. And at the time that we did the testing, SUFU was not available as a clinical test. So exome sequencing was able to provide a diagnosis at a time when there was no clinical testing available for this condition. So SUFU is an important negative regulator of the head shock signaling pathway, which normally is a molecule that binds to a receptor patch and activates a transcription cascade that promotes proliferation and cell growth. So the loss of the SUFU here is what's causing excessive head shock activity and too much growth. So Gorin syndrome or Nevoid basal cell carcinoma syndrome usually presents with basal cell carcinomas, so tumors of the skin, usually presenting after puberty, macrocephaly, jaw cysts, skeletal problems, and pits in the skin of the palms and the soles. And this is a question that comes up at the board. So if you have someone that has little pits that you can see here on the palms, that's usually the diagnosis. So they have an increased susceptibility to ionizing radiation, which is why these patients will not benefit from radiation, and we avoid it, both when we do surveillance, but also during treatment. So knowing the etiology is important so that the appropriate therapy is done and you don't make them worse. So 5% of those patients will develop medulloblastoma in the first few years of life, and 10% of those patients with medulloblastoma diagnosed before the age of 2 will have Gorin syndrome. So these children should be referred because they most likely have a germline predisposition syndrome. So in addition to SUFU, mutations in this head shock receptor patch 1 also cause Gorin syndrome, and they can have a very tall forehead with wide spacing of the eyes, and again, they can present with intellectual disability, deafness, and brain tumors. So even with these children that develop early on a large head, they could fall within this subset of kids that have excessive activation of the head shock pathway. And they can also develop scoliosis and rib abnormalities. So hopefully what we've been able to show you today are examples in which you guys as primary physicians play an important role in identifying these physical findings early on and these family histories so that they can be referred for evaluation by a geneticist, and ideally a clinic like ours where you have the merging of a multidisciplinary team that will allow patients to have access to care should they have an identified neoplasm. So identify them early allows us to counsel the family so that siblings can be tested and other family members before they become affected. Initiate surveillance plans and test additional members who may be at risk. By understanding the genetic etiology, hopefully I've convinced you that we can tailor both the surveillance plan but also the treatment plan once they actually undergo treatment for their neoplasms. And this idea of developing personalized, targeted, precise treatment plans is where we're moving with genomics. And I think this population is the most likely to benefit from that approach the sooner. So I would like to thank for the opportunity to present. Again, we thank the UCLA Genomics Clinical Center, who is facilitating the presence of this clinic. Obviously, our team that was introduced by Dr. Chang, the divisions of medical genetics and hematology oncology, who provide the support for maintaining it, and the funding sources that allow our research studies to continue. Thank you.